Hello dear students. So let's start with this important module on pneumonia. Pneumonia. So this topic is very important. Now I'm sure that in your routine clinical practice, management of pneumonia is always something that you should be very thorough with because it is such a common problem in the medicine wards, whether it be in the general wards or maybe in the ICUs or even OP management also. This is a very important topic that you should know of. So in this module, we are going to see in detail regarding pneumonia because this is going to be an exhaustive session because this topic deserves that much of an importance. I told you from the clinical point of view as well as from the exam point of view. So let's begin this module on pneumonia. First, let us try to understand what is this pneumonia. Okay, so you are hearing this term pneumonia. What does pneumonia mean? Pneumonia is nothing but an infection of the lung parenchyma. Okay, infection of lung parenchyma is what you call pneumonia. So when I say that there is an infection of lung parenchyma, I mean there can be an infection involving the alveoli, okay, as well as you may have a interstitial involvement. Interstitial involvement. So in certain pneumonias, you might have a predominance of your alveolar involvement. In certain pneumonias, you will be having a predominant interstitial involvement. Okay, so this is a lung parenchymal infection. And this infection, lung parenchymal infection, can be because of a bacteria. It can be because of, say, viruses. Okay, it can be because of a fungus. It can be because of a protozoa. So any of these, out of which the most common ones are the bacterial and the viral infections. So these are the etiological agents implicated in causation of pneumonia. Okay, all right. Now, for the purpose of classification, you subdivide pneumonia into various subtypes. Okay, so let's see what is the classification of pneumonia. Okay, what is the classification? This again is important. Now you're classifying pneumonia into various subtypes. You have the community acquired pneumonia, community acquired pneumonia. You have the hospital acquired pneumonia, hospital acquired pneumonia, and you have a ventilator associated pneumonia, ventilator associated pneumonia. So all these terms are actually self-explanatory. You know, the pneumonia that you acquire from the community, the hospitals, and a ventilator associated pneumonia. Okay, now there is another fourth classification, that is your healthcare associated pneumonia, health care associated pneumonia. Now I have given a separate color for this for a reason, that in the 2019 guidelines, okay, in the 2019 guidelines of the IDSA, okay, you have the IDSA and American Thoracic Society. So you have the IDSA ATS guidelines. So IDSA is the Infectious Disease Society of America, and the American Thoracic Society. They issued a combined guideline in 2019, and in 2019, in their position paper, they said that the use of this term healthcare associated pneumonia should not be there. So this term was actually taken off. So as of now, we have these three entities. Okay. So our discussion will be mainly centered around the community acquired pneumonia, but we'll be discussing the management part of the ventilator associated and hospital acquired pneumonia as well. Okay. So we will begin with the community acquired pneumonia. Okay, community acquired pneumonia, or you can even say it as a CAP, or the community acquired pneumonia. Now, when you talk of community acquired pneumonia, if you look at Harrison, there is a subdivision of this community acquired pneumonia based on the setting in which you develop this. Okay, so let's see that table. See, the microbial causes of a community acquired pneumonia by the site of care. That is, you may develop a community acquired pneumonia which can be managed in a outpatient basis. You can have a community acquired pneumonia which might require hospitalization. And in the hospitalization, it might be a non-ICU in the general wards, or this community acquired pneumonia might require an ICU admission. So it is quite obvious that when you have such a classification, the basis must be based on the virulence of the organism, which means the more virulent an organism is, he is likely to take the patient to the ICU, correct? So let's have that subdivision first. What are the organisms causing? Now, when you take into account the outpatient department, so suppose you have a pneumonia that can be managed in the outpatient department, the most likely cause would be a Streptococcus pneumoniae or pneumococcus. Now, at this juncture, let me tell you that not just the OP patients, whether it be IP, and if it is IP, whether it be non-ICU or ICU, always the commonest organism associated with a pneumonia is Streptococcus pneumoniae. This is one very important multiple choice question that you have got to know, because it is not that when it comes to the ICU setup, or maybe a virulent pneumonia can take you to the ICUs, as well as it is something that can be managed in the OPD as well. Okay, so do not think that pneumococcal infection is restricted to a less severe form of pneumonia. It can be a spectrum, especially the virulent forms can cause severe manifestations. Now, in the outpatients, you can have, in addition to pneumococcus, the second would be Mycoplasma pneumoniae, okay, which again is an organism that can cause pneumonia with some atypical features as well. We'll discuss that. You can have H. influenzae, you can have chlamydia pneumonia, as well as the respiratory viruses. So these are the organisms that can cause a community acquired pneumonia, mostly which can be managed in an OP basis. Coming to the pneumonia, the community acquired pneumonias which might require a hospital admission. See, it might be non-ICU. Okay, non-ICU, again, the list of organisms you see, after Streptococcus, it is the Mycoplasma, Chlamydia, H. influenza, Legionella, and respiratory viruses. So you see another organism is actually peeping in, that is your Legionella has come here. So which means, Legionella is more likely to get you into the hospital. Okay. Now in ICU patients, again, they are our real villains, the etiological agents. You have your Streptococcus pneumonia, but now comes who? Your Staph aureus. Again, your Legionella. Gram-negative bacillus comes in. The virulent H. influenzae as well as respiratory viruses. And to say not the least, you now have your COVID-19. Okay, your COVID-19, which again can present with a spectrum of manifestations. Some of them, we can go for a home care as well, but it can produce severe manifestations which might make the patient get into the ICU as well. Okay, so this is the list of organisms, a very heterogeneous list. So which is why we like to group it. Okay, so how do we group this heterogeneous list of organisms? See, the organisms that cause a community acquired pneumonia, you can group them into two. One is the list of organisms that cause a typical pneumonia, and the other ones which cause a atypical pneumonia. Okay, typical, atypical. Now, typical pneumonia, the organisms, the most common one is going to be your Streptococcus pneumoniae or the pneumococcus, that is the common one. You have the H. influenza. You have your Staph aureus. You have your Klebsiella, and you have your Pseudomonas as well. So these are the organisms. So remember, Pseudomonas also can produce, okay, and that can also get the patient, it's most often, since the Pseudomonas is not a soft organism, it is likely to produce severe manifestations. So these are the organisms that can cause a typical pneumonia. Now coming to atypical pneumonia, as the term indicates, it should have some atypical features. So atypical features means, per se, when you want to divide it typical versus atypical, the organisms which cannot be routinely cultured in a culture media, okay, or which cannot be obtained in a gram state, they are the ones which you would group as the atypical group. Of course, they have some atypical features as well, but that is there with any organism. See, you have a typical pneumonia group. Do you think always a pneumococcus infection would behave the same like a staph infection? No, because if you take into account staph infections, they're likely to produce certain complications like, say, cavitations. Okay, so cavitations or pneumatoceles. So cavitations and pneumatoceles are more common with your Klebsiella pneumonia and Staph aureus. So the atypical group would include the organisms like, you have your Mycoplasma, the Chlamydia pneumoniae, then you can have your Legionella, Chlamydia pneumonia, Legionella. Then the various viruses like your adenovirus, the respiratory syncytial virus, maybe you can say your COVID-19, okay. So your influenza. So all these are atypical pneumonia causing organisms. That is how you would like to subgroup into the typical as well as atypical organisms. Very clear. The organisms causing a community acquired pneumonia. All right. So again, let me tell you once again, the most commonest organism will be the pneumococcus, okay, causing a community acquired pneumonia. Now, see, when you divide this into a typical as well as atypical, you should always know that, when you want to treat, when it comes to practical aspect, when you want to treat a pneumonia, you are more concerned whether this is the pneumonia is caused by an organism which is drug resistant. As you know, in the world of antibiotics, the buzzword is the antibiotic resistance. So you have a lot of antibiotic resistance developing, and you are always concerned if a particular pneumonia is caused by a resistant organism or not. So the point that I'm coming to is that, when do you suspect that, okay, this could be a colonization by an organism which is, say, drug resistant? So there are certain high risk factors that you should take care of, okay, so which will give you an indicator. It is not that the mere presence of one high risk factor tells you that this is going to be a resistant organism, but when you have certain risk factors in combination, maybe 2 or 3 risk factors in combination, you have a fear this could be a resistant organism that has caused the pneumonia. So again, I take your attention to a table in Harrison. So this is the table that shows the risk factors for pathogens resistant to the usual therapy for community acquired pneumonia. Okay. So what are those risk factors? You have certain risk factors for the multi-drug resistant gram-negative bacteria and MRSA. You have certain risk factor for nosocomial MRSA, and you have some risk factors for community acquired MRSA. So again, just you should have an overview on what are these risk factors, because when it comes to MCQs, you might be given certain clinical scenarios in which the examiner would hide these risk factors in the long question, and it is up to you to figure out, okay, this is likely, I'm dealing with a resistant organism. Okay, so because of which your idea should be very clear on how and what are these risk factors. Okay, so see, if you have a hospitalization for more than 2 days in the previous 90 days, so that is in the last 3 months, if you have had a hospital admission, so which it is likely that your hospital admission, if you have a hospital admission more than 2 days, it should be for a reason. So it may be an infection that has made your immunity status go a bit low, or maybe you were admitted because you were a chronic kidney disease patient and you wanted dialysis, So there was some reason for a hospitalization for more than 2 days, and which would have had an impact on your immunity, not the hospital stay. I mean the infection per se, which has made you admitted in the hospital, and use of antibiotics in the previous 90 days, and immunosuppression, non-ambulatory status. Suppose you had a procedure for a hip replacement and then you were non-ambulant and you were at home, and then tube feedings, gastric acid suppression, severe chronic obstructive pulmonary disease or bronchiectasis, which has damaged the lungs. Again, the first two are the same, which I talked about earlier. Then chronic hemodialysis, and if you have a documented prior MRSA colonization, that is maybe a couple of months back you were admitted for an infection and it was found that you have an MRSA infection. So such individuals, again, the likelihood of having a recurrent MRSA infection is high. Okay, naturally his immune status is compromised. And congestive heart failure, gastric acid suppression, because when you have a prolonged gastric acid suppression, colonization by organisms in the gastric mucosa, then you might have some gastric reflux as well. So then there is a chance of recurrent aspirations leading to pneumonia. Then coming to the community acquired MRSA, cavitary infiltrate or necrosis, because suppose you have had a hospital admission where you have had a pneumonia which has cavitated, or you had a necrotizing pneumonia, which means your pulmonary reserve is affected. You have already had some damage, which means a secondary superimposed infection is likely. And gross hemoptysis, neutropenia, rash, concurrent influenza, which means whenever there is a concurrent influenza, it's again likely to bring down your immunity, especially the cell-mediated immunity comes down. Young previous healthy status, it just means one thing. See, if a person is a young otherwise healthy patient who has got a pneumonia, do you think this is going to be a less virulent organism that has caused pneumonia in this patient? No. Obviously, the virulence status must be high. So in such a scenario, you should suspect that whether this is a MRSA. And also summer month onset. This again is just to tell you that if you have certain risk factors in combination, you are likely to suspect some resistant organism causing pneumonia in this patient. All right. So that is also clear. So in addition to the group of organisms that you learned, plus the risk factors, I am sure you would have also heard about anaerobes causing pneumonia. Okay. So till now, we were focusing on the aerobes causing pneumonia, but I am sure that you know that anaerobes also can cause pneumonia. See, anaerobes causing pneumonia, you normally would have anaerobe colonization in your oropharynx. So usually, your tracheobronchial tree is, it's not a highway. It has lots of branches. So even if you have some normal colonization, it does not reach the alveoli because throughout you are having various host defenses, okay, which are protecting you. Okay, you have host defenses which are protecting you. And when you have host defenses which are protecting you, the organism does not gain access to the alveoli, which means suppose you have a oropharyngeal colonization, and even if you have a bit of secretions, just going down your respiratory tract, you have all these cilia that is protecting you, that is trying to, kill the organism, which is likely to produce an infection. So you have all the host defenses. Now what happens is that if for some reason it is able to evade all these defenses, come through the tracheobronchial tree to the alveoli, even then what happens is that in the alveoli you have the pulmonary alveolar macrophages. Pulmonary alveolar macrophages. So these macrophages, they are very powerful, very powerful. So these macrophages again would assist in killing this harmful organisms. The point I want to tell you is, in normal scenario, though you have anaerobe colonization, the host defenses the branched tracheobronchial tree and the macrophages in the alveoli, they will protect against infection. But anaerobe infection can occur in certain scenarios, like when you have, suppose you are having a altered sensorium. For some reason, a patient develops a altered sensorium. So altered sensorium means, normally I said you have all these protective defenses, you have your normal gag reflex, you have your cough reflex. So all these reflexes are there. So normally you have all these protective reflexes. But what happens is that when these protective reflexes are compromised, as in case of an altered sensorium, then what happens is that it is almost a free passage for the organisms to the alveoli. And especially if it is someone who has a bit of immunosuppression also, the chance of an anaerobic infection is high. So in what sort of patients do you expect anaerobic infection? One is altered sensorium. Maybe you have an alcoholic who is in an inebriated state, develops an aspiration, the host defenses are totally compromised, okay, is in a state of inebriation, and then what happens is that these organisms reach the alveoli. Sometimes you might have a heavy microbial load. So when you have a heavy microbial load reaching your alveoli, sometimes your pulmonary alveolar macrophages may not be able to contain the infection. So in such a scenario, when the pulmonary alveolar macrophages are not able to control the infection, then what happens is that you are likely to get the anaerobic colonization. Okay, that is how you will get a anaerobe infection of your lungs. Okay, so I hope that part is also clear. All right, now the next possible question that you might get in your exam is again with respect to a table in Harrison. See, we have discussed a lot of organisms, correct? So each organism would have certain peculiarities. Or in the exam, from an MCQ point of view, let me put it in this way, that if you are given certain hints in the question, you can say that probably this is due to an infection with this particular organism. Okay, so let us go through that list, the important ones, okay, so that solving MCQs will be easy. Now, first one is alcoholism. Now, let me remind you one thing. I told you in alcoholism there is a chance of anaerobic colonization and infection. But even in anaerobes, even in alcoholics, the most common organism that would cause a pneumonia would be your Streptococcus pneumoniae. Okay. Okay, it is only when an alcoholic goes to the state that he is lying down somewhere and is aspirated. That is the scenario in which he is likely to get a anaerobic infection. Okay, it is not that in alcoholics it should be a anaerobic infection. Alcoholics also, most common is a pneumococcal infection. You can have anaerobe infection, Klebsiella. Klebsiella is also very important. It is having a predilection for involvement of or involving alcoholic patients. Acinetobacter and tuberculosis also. Okay, alcoholics, there is a high chance of producing a tubercular pneumonia. So that also I just want to tell you. Tuberculosis is being discussed separately, but you know that that can also produce an infection of the lung parenchyma. You can have a tuberculous pneumonia as well. Okay. Now a COPD. Again, this is a very important question. They might ask you which is the most common organism that is likely to produce a pneumonia in a chronic obstructive pulmonary disease patient. So specifically they are asking that question. Your answer is going to be a H. influenzae. Haemophilus influenzae is having a high predilection for involving or causing pneumonia in case of COPD patients. But is it just regarding H. influenza? No. You can also have Pseudomonas, Legionella, Pneumococcus, Moraxella, Chlamydia. All these organisms can cause, but remember, most important, H. influenzae. Okay? All right. Then another very, very important question. You might be given a question like, you have a patient who is having a bronchiectasis. That is, there is a structural lung damage, or maybe there is a patient with a cystic fibrosis where there is some structural damage to the lung. In such an organism, such a case where you have already a destroyed lung, the organism that is likely to produce will be a pseudomonas. Very, very important. So structural lung disease, pneumonia, most likely it is pseudomonas. But remember, it's not just pseudomonas. You can have Burkholderia and Staph aureus. So though you must always know the most important organism, just go through the others as well, because in the exam, sometimes you might be asked a question, which of the following organisms causes pneumonia in a patient with structural lung disease? And probably you might have Pseudomonas, Burkholderia and Staph aureus in the options. So in that scenario, you will have to go for all of these. Okay. Now in patients with dementia, stroke and decreased level of consciousness. So what is impaired here? Your airway defense mechanisms are compromised, and here comes our anaerobes, the oral anaerobes. You can also have gram-negative enteric bacteria also causing pneumonia in such patients. The lung abscess, again very important. So lung abscess, again, you can have a lung abscess in somebody without any pre-existing illnesses. Okay, for example, an alcoholic, again, inebriated state, aspiration, anaerobic lung abscess. Okay, so that is a very common scenario. And that is what you call a primary lung abscess. Okay, but you may also have a pneumonia developing in a patient who has already had a structural disease of the lung. So in that scenario, you can have a community acquired MRSA. Okay, community acquired MRSA. So it is a common organism causing a secondary lung abscess. Okay, already there is some previous structural damage to the lung. Okay, now yes, you can also have abscess with fungi, tuberculosis, atypical mycobacteria, etc. Okay, so always keep in mind this atypical mycobacteria. Remember, we studied about bronchiectasis. There also we learnt about atypical mycobacteria causing an infection. So keep in mind they can also produce pneumonia. Then the travels, we see the travel outside, that is less likely to be asked as a question. But again, this one is likely to be asked as a question. In fact, has been asked many times. If you are having a stay in a particular hotel, or maybe you are traveling in a cruise where you have a closed probable circulation and you have air conditioners. So whenever you have a closed environment and there is a air conditioner going around, so in such a scenario, that is when you should suspect Legionella. And Legionella is it is a cause of an atypical pneumonia. All right. Then exposure to bats, again a single liner, maybe a few factual MCQs also you can expect. So histoplasma is well known to produce infection after exposure to bats. Exposure to birds, Chlamydia psittaci. Now remember this, I already told about Chlamydia pneumoniae in the atypical organism group, but this is the Chlamydia psittaci. So these are organisms which you will consider in certain special scenarios. They are not organisms that are going to cause say routine pneumonias. So in your exam also, don't think that just because a patient is having a bird at his home, he is likely to get a psittacosis. Okay, it is only in certain special scenarios you would think of these rarer organisms. Then exposure to sheep, goats, you will think of Coxiella. And when you think of rabbits exposure, it can cause Francisella tularensis is the organism that can cause. Now all these last ones is again probably can be asked as factual questions. I cannot totally rule out this being asked as a question, because some examiners might be interested in such fancy questions. They might ask you pneumonia in somebody who has got exposure to a rabbit. So Francisella tularensis. So it may be asked as a question, especially since this is a table given in Harrison. I feel always any table that is given in Harrison is always high yielding. So you have got to learn that. Okay. All right. So that much you have learned. So far we have learned in detail regarding the etiological agents. Correct? No? We were discussing regarding the probable etiological agents causing the pneumonia and how they are different from one another. Okay. And probably one more point, you can just add on is that a pneumonia that is likely to present with hyponatremia, okay, as a clinical feature is again Legionella. So does that mean that the next patient that you're going to see in your wards with a pneumonia having a sodium value of 132 is going to be a Legionella? It's not that. But if you have a atypical presentation of a pneumonia in which you have not been able to demonstrate any organism, and you find that the patient is having a significant hyponatremia, maybe 118 milliequivalents per liter, so in that scenario, you would consider a Legionella pneumonia. Okay, so which is why there is always a danger when you learn for entrance exams, because sometimes certain facts can get imprinted too much on your mind, so that when it comes to the actual scenario, you might think more of rarities. Okay, so the more you learn, the more rarer diseases you know, and yes, you might think of the possibility of rarer diseases. I'm not saying that you should not think of such diseases. Definitely yes. But every time, the beauty of clinical medicine is that common things are common. So always in a clinical scenario, think in the normal sense first. And it is only after that, you think out of the box. Okay. But don't straight away jump out of the box, and then, when you come back in, it might be late. Okay. So always in this particular module, let me tell you one thing: common things are common. Okay, and always approach patients with a clinical sense and a logical sense also. So I think there is always a balance between your clinical sense and a logical sense, because only then that you would be able to treat the patient in a logical manner. Because when it comes to clinical management, see, any disease that you learn, at least many of them would have some or the other guidelines, but guidelines are just to guide you. Okay, it is not that you have to evaluate only as per the flowchart in Harrison. Certain scenarios might require you to be more aggressive. Okay, because if you have a patient who is admitted with a severe life threatening illness, the time in your hand is less. So in that scenario, you cannot be a, say, somebody who is very slow. You cannot be a Rahul Dravid there. You have got to be aggressive. Okay, so you've got to be a Tendulkar or a Sehwag or a Dhoni. Okay, so you've got to be a bit aggressive there. So it depends on the clinical scenario as well. All right. Okay, so far we learned regarding the organisms in the organism list. And now let's see what is the actual pathology that happens. See, in pneumonia, I told you there is an infection of the lung parenchyma. And the infection of the lung parenchyma can produce exudation. Okay, and the alveoli may be filled with exudates. So let me tell you straight away, there are two types of pneumonia that you can think of. One is your bronchopneumonia and lobar pneumonia. So as in this picture, I've taken this from Robbins. So as you can see in this picture, lobar pneumonia means it is an infection that is probably involving a lobe. Okay, you say that there is a lobar type of consolidation. This is more or less a uniform type of consolidation. So that will be the key word. It is almost a uniform type of consolidation. But sometimes an infection can result in a patchy areas of consolidation. As you can see in this picture, yes, you see patchy areas of consolidation. So that is what happens in a bronchopneumonia. So in lobar pneumonia, it is primarily a alveolar disease. But in case of bronchopneumonia, you can have affection of your bronchi as well. Okay, yes, alveolar affection plus a bronchi affection. So you can have a bronchopneumonia as well as a lobar pneumonia. So just again a picture from Robbins, again, which compares the two types of a pneumonia, that is your bronchopneumonia and a lobar pneumonia. You see, this is the autopsy specimen. You see, it is almost like a consolidation. So this is actually a more severe form. Do not think that all lobar pneumonias are like this. This is actually involving the whole lobe. So lobar pneumonia doesn't mean that the whole lobe has to be involved. It is just a pattern of involvement, a uniform consolidation. So this is actually a lobar pattern, okay, lobar consolidation. Whereas the others, where you have all these patchy areas of consolidation, that is a bronchopneumonia. Bronchopneumonia. Okay, all right. So what happens is that the disease, I said, primarily is at the alveolar level, correct? No, it is primarily at the alveolar level. see, you have the alveoli here and you have the capillary, pulmonary artery. This is the pulmonary capillary level and the pulmonary vein level. And what happens in pneumonia is that, see, there is some infection of the lung parenchyma. And what happens is that there are certain stages through which the disease pathogenesis proceeds. And you have got to know that. So, and these particular stages which I am going to describe is classically described in case of a lobar pneumonia. Okay. So, we are going to see the stages in the pathogenesis of a lobar pneumonia. So, the first stage will be a stage of congestion. Stage of congestion. Okay. Second stage is the stage of red hepatization. Red hepatization. And third is a stage of gray hepatization. And finally, you would have a stage of resolution. So what are these stages? These are the stages through which a lobar pneumonia would progress. See, stage of congestion means this is the stage where you have the, normally you would have this particular part, okay, the alveolo-capillary membrane, correct, no? You have the alveolo-capillary membrane. So what happens is that in the stage of congestion, you have got a leaky alveolo-capillary membrane. You have got a leaky alveolo-capillary membrane. The membrane is very leaky. And when you have a leaky alveolo-capillary membrane, what happens is that you will have the integrity of the capillaries would also be affected. So there will be a flow from this endothelial cells of the capillaries. You have the proteinaceous fluid which reaches the alveoli. Okay. So in the stage of congestion, you have proteinaceous fluid. You have proteinaceous fluid reaching your alveoli. So normally in your alveoli you have the air, but here what happens is that you have fluid inside the alveoli. If you remember when we discussed regarding respiratory failure, so there I have mentioned that there occurs something known as alveolar flooding. Okay, alveolar flooding in case of a pneumonia, which means in case of a pneumonia you would have all these fluid, or maybe in subsequent stages proteinaceous fluid, or maybe some inflammatory cells inside your alveoli. So previously your alveoli was free, it was full of air, but now you have all these fluid, and subsequently the inflammatory cells will come in the subsequent stages. So it's almost like a alveolar flooding. So that is what happens in the stage of congestion. Proteinaceous fluid, a leaky alveolo-capillary membrane, proteinaceous fluid, alveolar flooding. And then comes the stage of red hepatization, which means it's got to do something with the red, which means RBCs. So what happens is that in addition to the proteinaceous fluid, you also would be having RBCs and your neutrophils, the polymorphonuclear leukocytes. So these would also gain access to your alveoli. Why does it gain access? Because the alveolo-capillary membrane is leaky. It has gained access to the alveoli. So that is the stage of red hepatization. See, why do you say it is hepatization? You're talking of lung. Why bring in liver here? See, normally, the alveoli, the alveoli is filled with air. But in pneumonia, what happens is that it is like your lung parenchyma is solidified, correct, no? There is a solidification of lung parenchyma. There is a solidification of lung parenchyma. So which means all your exudates, the inflammatory cells will be filling up. So because it is from the normal pneumatic phenotype of a lung where you have air, it is almost like it is becoming a solid organ, at least in that particular part. So that is why you coin this as a red hepatization. Okay. And then suppose the infection is relatively controlled, it goes to the stage of red hepatization where you do not have further RBCs coming into the alveoli. Yes, but you might have the breakdown products of the RBCs plus your polymorphonuclear leukocytes. So in this particular stage, what you are having is you are having the breakdown products of RBCs like your hemosiderin, breakdown products of RBCs, plus again you have your polymorphonuclear leukocytes. So that is what you have in the stage of gray hepatization. And then it goes to the stage of resolution, where your pulmonary macrophages would be able to contain your infection. See, your main man in the alveoli, okay, whom you should pay good respect to is your pulmonary macrophage, because that is what is the main line of defense of your alveoli. Okay, that is the main line of defense of your alveoli. So if the defense is compromised, either because you are having an immune compromised state or because you were perfectly fine, but the extent of infection is so severe that your macrophage is not able to contain the infection, or you can say the macrophages are overloaded. In that scenario also you might develop a infection. Okay, so if the alveolar macrophages are able to contain the infection, it will go to resolution. However, if the disease process is very severe, okay, it will not go to the red hepatization and the stage of resolution. You can have complications developing. You can have necrosis. Okay, you can have necrosis. You can have cavitation. You can have pneumatoceles. You can have empyema developing in. Okay, you might have abscess. So that is when all the complications set in. And that is when you say this is a complicated pneumonia. Okay. On top of a pneumonia, you might have any of this. You say this is a complicated pneumonia. Okay, which is very important. So that is the usual time course of events in case of or the progression of events in case of a lobar pneumonia. Okay. So I hope that part is very clear. Okay. So you have understood so far what is pneumonia, what is the whole list of organisms that can cause pneumonia, and MCQs pertaining to each individual organism, and again what is lobar consolidation, what is bronchopneumonia, and what are the stages through which pneumonia can proceed to. Now let's see the clinical features of pneumonia. Okay, how do they clinically present? Okay, so that is very important. Okay, clinical features. So clinical features of pneumonia. First of all, let me tell you, I already told you, in the various stages of infection, you have all these inflammatory mediators like your neutrophils, and again you have your RBCs also going inside your alveoli. But remember, along with this you can also have cytokines. Cytokines like your interleukin 1, TNF alpha, all these cytokines are also very important in the pathogenesis. So which means you can have fever as a manifestations, because these cytokines are actually pyrogenic cytokines. They can cause fever. So pyrogenic cytokines, they will cause fever. So one feature is going to be fever. Okay. Then you can have, obviously you can have cough. Yes, you can have cough. Is it going to be a dry cough or a productive cough? What do you say? See, in early pneumonia, what you get is going to be a dry cough. You say that it is a dry cough with rusty sputum. Now, why do I say that it is a dry cough with some rusty sputum? Because initially it is totally dry. Why dry? Because inside the alveoli, you have the alveolar macrophages which would eat up all these inflammatory cells. So, or whatever exudate is there. So, you have a battle that is going on, in which you have the macrophages in your side. So whatever exudates you have in this alveoli, okay, so if you have exudates in this alveoli, initially the macrophages would try to take these exudates. So at that time it would be a dry cough. But then once the stage of red hepatization happens and you have the RBCs, subsequent breakdown of RBCs to hemosiderin. So once the hemosiderin is formed, what will happen is that you will have a rusty sputum. Okay, rusty sputum. So you have a dry rusty sputum, but then what happens is that it progresses so much so that the infection exceeds the capacity of the macrophages. So that is when you get a purulent sputum. Okay, you get a purulent sputum. So initially you might have a dry cough with a rusty sputum, and then you might get a purulent sputum. So that is about cough. Yes, you will have breathlessness also. Okay, breathlessness also. So why breathlessness? Because normally you know that in your alveoli you have the gas exchange taking place. So normally the alveolo-capillary membrane should serve as a passage for these gas exchange. But what happens is that since all the alveoli is being flooded with all these inflammatory mediators and your exudates, what happens is that the effectiveness of the gas exchange is not happening. Okay, so because I told you there is alveolar flooding happening here. So because alveolar flooding is happening here, oxygen is not able to gain access to your the arterial side, which is why your PaO2 will actually fall. Okay, and we have already learned in the respiratory failure module, I have already discussed that you will get a, if the disease progresses, you might get a type 1 respiratory failure. Respiratory failure. So in which your PaO2 will decrease. But what about your PaCO2? See, the patient is hyperventilating. There will be some sort of a tachypnea also. So carbon dioxide will diffuse out from the alveolar capillaries to the airway. So there will either be a normal or decreased PaCO2. Decreased because when there is too much of a hyperventilation, there can be washout. Okay, so that will happen. So type 1 respiratory failure is the one that occurs in pneumonia. But mind you, all patients may not go for a respiratory failure. Okay, so that again is telling you the importance of an early identification and treatment. So breathlessness can be there. And so fever, cough, breathlessness, these are the important symptoms in case of a pneumonia. But in addition to this fever, cough, breathlessness, you may also have certain atypical features. Okay, which means you might have chest pain as an atypical feature, because when you have a pneumonia that is involving your lung parenchyma, if your adjacent pleura is also involved, that is whenever there is a pleuritis, you might also have a chest pain also. And also if you have a basal pneumonia, okay, involving the basal lung segments, you may get some abdominal pain as well. Some abdominal pain, some nausea, some vomiting may also occur as atypical features. And again, certain pneumonias are very well known to produce certain atypicalities, like your mycoplasma pneumonia. So mycoplasma pneumonia is often referred to as a walking pneumonia. Walking pneumonia because, see, it is predominantly producing an interstitial involvement. I told you certain infectious agents would cause an alveolar involvement predominantly. Certain would cause an interstitial involvement. So mycoplasma, chlamydia, the viruses, all these predominantly produce an interstitial inflammation or an infection. So in such a scenario, it is the interstitial infiltrates that you would see. And in case of mycoplasma, the patient will not be that much symptomatic. So you might have a patient who is presenting to you without much symptoms, but his X-ray might tell you that he is more symptomatic. That is, radiologically, it might be like he has diffuse interstitial infiltrates bilaterally. But again, symptom-wise, he might be walking to your OPD. He might not be having any severe breathlessness, maybe mild degree of breathlessness, but that again, when you compare with the radiology picture, it might not be that much symptomatic. Okay, radiology, it's again maybe diffuse infiltrates you can see. So that is walking pneumonia. And also this mycoplasma pneumonia is associated with certain other atypicalities, like you may have an associated hemolytic anemia. Okay, this is associated with your hemolytic anemia. So Steven-Johnson syndrome. Okay, so these are again some of the atypicalities that can occur in a mycoplasma pneumonia. Okay, not just this, you can have some ear problem, sometimes some cerebellar affection. So atypical or extrapulmonary manifestations are more for your mycoplasma pneumonia. So if you have a pneumonia, question on pneumonia with lots of extrapulmonary manifestations where the HP has dropped, there is some hemolysis. So in such scenarios, you can think of mycoplasma as a possible etiology. Okay. So you can have the classical features and the atypical features also. And about the examination findings. Okay, examination findings. So naturally you will be having any patient, he would be febrile. Okay, and he would be having tachypnea and tachycardia, correct? Tachypnea, tachycardia will be there. And coming to the examination findings, you may have an anemia in especially mycoplasma pneumonia cases where there can be hemolytic anemia. But about the other system examination, that is your respiratory system examination, you must know that this in case of a pneumonia, I'm talking in general pneumonia, so you can have certain important findings, which again the examiner can ask you in the form of the long question, putting all these findings. So the findings are, one is you will get a increase in the vocal fremitus and resonance. So there is increased vocal fremitus and vocal resonance. So that is primarily because you are having a solidification of the lung parenchyma. Okay. Always remember, a solid lung conducts sound better than a lung which is filled with air. Okay. So you will have an increased vocal fremitus, vocal resonance. Okay. Again, but the most important point that you have got to know is that you will have a type of breathing that is known as your bronchial breathing. Okay, bronchial breathing, because normally you have the vesicular breathing, but in case of consolidation, the most important finding that you should look for is a bronchial breathing. And you know that in bronchial breathing you have your expiration, which is as much as, or maybe even this is how you draw it. Okay, that is your expiration, this is expiration, this is inspiration. So your expiration will be as much or maybe longer than the inspiration sometimes, with a definite gap between your inspiration and expiration. So that is what you call your bronchial breathing. Whereas in case of your normal vesicular breathing, this is how it goes. This is the inspiration, this is the expiration. So the inspiration will be longer than the expiration and there is no gap between inspiration and expiration. So this is your vesicular breathing and this is your bronchial breathing. Vesicular breathing, bronchial breathing. And also the other findings, you also can have crepitations, correct? You can also have crepitations in case of pneumonia, again very important. And you may get other findings also. What are the other findings? You may get, just because of this solidification, you might get important findings like bronchophony, egophony, and whispering pectoriloquy. Okay. So whispering pectoriloquy means, you're auscultating and you're asking the patient to whisper. And just because this lung parenchyma is very much solidified, even that whisper you will be able to hear better. Because I told you a solid lung parenchyma will conduct better. Okay. That is your whispering pectoriloquy. And egophony means, again you are auscultating and you are asking the patient to say E. Okay, you are asking the patient to say E. So when you're asking the patient to say E, it might, when you auscultate, it might sound like a ah. Okay. Okay, so you ask the patient to say E, and when you auscultate, it might be audible like a ah. Patient might actually be saying E, but you are hearing it as a ah. That again is because of the consolidation of the lung parenchyma. And again, bronchophony is also because of the consolidation of lung parenchyma. And all these features are again a reflection that a solidified lung is better conducting than a lung which has lots of air. So that you have got to keep in mind. So these are the important examination findings that you will get in a patient with a pneumonia. But always remember one thing. Sometimes a pneumonia may be associated with a para-pneumonic effusion, which is not rare. You may have a parapneumonic or a reactive effusion associated with a pneumonia. And if you are having a parapneumonic effusion, then some of the auscultatory findings might differ. You might not be able to demonstrate an increased vocal resonance or a vocal fremitus, or you might not be able to demonstrate the egophony, bronchophony, whispering pectoraloquy. Okay, so that happens when you have a parapneumonic effusion that has set in. Okay, so that is very clear. So you have learned regarding the examination findings in case of a pneumonia as well. Okay, all right. So now we will go to the the risk stratification in case of pneumonia. Okay, suppose you have got a patient, you have a patient in front of you. So suppose you have, this is a COVID times, so you have got to prioritize your admissions. So do you have any scoring system to prognosticate? Okay, it is primarily not meant to institute an antibiotic therapy. This is meant to prognosticate patients into groups. So for that you have a scoring system that is known as a Curb 65 scoring system. Curb 65 scoring system. So what is this Curb 65 scoring system means? There are certain parameters in this scoring system. C stands for confusion. U stands for your blood urea nitrogen, which is more than 20 milligram percentage. R stands for your respiratory rate. So each is given a point of 1. Okay, 1. So respiratory rate, if it goes more than 30, and if your blood pressure, if the systolic is less than 90, systolic is less than 90, and your diastolic is less than 60. So it is or systolic less than 90 or diastolic less than 60, you will go for again 1 point. So C, U, R, B, and then finally you have age more than 65 years. Age more than 65 years. Here again you will give a point of 1. So 1, 2, 3, 4, 5. Okay, total 5 points. Now you will look for the Curb 65 score in a particular patient to decide on whether this patient requires admission or not. Okay, because definitely you have got to prognosticate, because only then you would be able to decide which patient requires an inpatient care and maybe parenteral antibiotics. Because remember, all cases of community acquired pneumonia are not managed in the same way. You have differences. So you see here, if the Curb 65 score is 0 or 1, you can manage it on an OP basis. Okay, because the organisms that has caused it, we are assuming that these are the ones which have caused pneumonia, which can be managed at an OP basis. If it is 2, you can again consider a hospital-based supervised treatment, which means it is better to admit that patient, maybe in the wards. But if the score is 3 or more, preferably, you go for an ICU admission. Because 3, 4, 5 all means, is belonging to the high risk category. So which means if you have a 65 or maybe a 70-year-old male who presents with a fever, cough, breathlessness, and sometimes hemoptysis also. Okay, certain type of pneumonias, especially if it is necrotizing, that is, it is eroding, and it is probably eroding a blood vessel also, it can cause hemoptysis. See, normally in case of pneumonia, you won't get hemoptysis because that is just an infection of the lung parenchyma. There is no destruction that is happening. Whereas in bronchiectasis, there is more likely chance that you might have a hemoptysis also because there is destruction happening. So the point is, if the patient presents, elderly is presenting with some cough, breathlessness, and he is having a deranged renal function test, maybe as a result of a pre-renal acute kidney injury, and you have, say, this patient who is very much tachypneic also, he is in hypotension also, probably he's developed sepsis. So does this give you some idea? Yes, it gives you the idea that this is a high risk patient. You have got to admit this patient. Okay, so this is again a scoring system which will help you in the prognostication. Okay, so get the patient in if you are having a higher Curb 65 score. Now once the patient is in, okay, you have admitted the patient, how will you investigate further? Yes, you have got to go for a complete blood count. So yes, you are expecting a leukocytosis, because when there is a naturally an infection, you might expect a leukocytosis. And yes, the ESR also might be elevated. If you do a CRP, again might be elevated. Okay, so you do a complete blood count. Along with that, it is definitely necessary that you go for a renal function test, liver function test, because see, at the end of the day, pneumonia is a systemic illness. So which means, it can produce multi-organ dysfunction if it is untreated. So you have got to pick up whether there is some acute kidney injury that has already been there in this patient. So you have got to go for a full blood investigation, and then you can go for a sputum study. So sputum study, you can go for a gram stain. You can go for a gram stain. You can go for culture, and especially yes, COVID. If you are suspecting, you should go for a RT-PCR also. Then regarding blood culture, see, the yield might not be that great unless the patient has had a true systemic involvement. It's like it is a pneumonia progressing to a septicemia. Then you are likely to isolate the organism more, but still you have got to go for a blood culture as well. And yes, chest x-ray is very important. Chest x-ray again is very important. And in certain scenarios, you might go for a CT thorax. That is only in certain scenarios. It is not mandatory that each patient with a pneumonia, you go for a CT thorax. It's often when you have a complicated pneumonia, or maybe you are having a non-resolving pneumonia. Non-resolving pneumonia, which means, you have started your management. But still, the patient with antibiotics, but it is not getting resolved. So let's now have a look at few of the chest x-rays. So see, what do you see here? See, in case of consolidation, okay, in this chest x-ray, consolidation would appear bright, okay, in a chest x-ray. And you can see there is obviously a region of consolidation that is predominantly involving the right middle lobe. And so this is a right middle lobe consolidation. Okay, right middle lobe consolidation. So there is another point that I want you to know, okay, which you might have learned in your radiology lessons as well. Especially when you have a right middle lobe consolidation. See, are you able to appreciate the margins of the cardiac borders on the right side very much? No. So it is slightly obscured. So this is what you call the Silhouette sign, because the cardiac silhouette is obscured by a right middle lobe consolidation. That is what is called a Silhouette sign. Okay, very clear. It's called a Silhouette sign. Important. Now, next point, you see here, as you can see, yes, there is definitely, consolidation is there. Okay, lobar consolidation is there. So, see, along with this consolidation, another point, I just want you to, I'm showing you this picture primarily for that. You see the white arrow, you can see that there is a region like this where you can see the air. Now I'll just take it off. You can see air within the area of the brightness, okay, or in the region of consolidation. So this is what you call a air bronchogram. Okay, this is what you call a air bronchogram. That is, you can see an air bronchogram in a lobar consolidation. That is, when you have a lobar consolidation, always remember your bronchi are not affected. So you have all these tracheal generations in the tracheobronchial tree. So you know that the bronchi are affected, so the bronchi will be having air. So the consolidation is primarily because the alveoli is filled with fluid. So you will have air inside the bronchi, which can be appreciated as the air bronchogram. Air bronchogram. Okay, you have the air bronchogram. Okay, so the red arrow is just showing the region of consolidation. So you have got to know that you can have air bronchogram in case of consolidation. Because see, if it was a case of an effusion, okay, I'm not talking about this case. Suppose if you have in the lower region, you are having a fluid, you are doubting whether this is actually a fluid or is it a region of consolidation. If you see air bronchogram, you can be quite sure that, okay, this is not an effusion, this is going to be a consolidation. Okay, so that again is important. Now next, see this particular patient. Okay, just see the X-ray, and in the setting of a community-acquired pneumonia, what is the finding? So you have got a consolidation. I'm sure that you would have picked that up, involving the right middle zone as well as the right lower zone. But is there something else that you're able to see? Yes or no? See, I'm sure that you would have been able to see the costophrenic angle on the left side, but are you able to see it on the right side? No, which means there has been a blunting of the costophrenic angle, which is probably because there is some fluid here. So this is actually a pneumonia with a parapneumonic effusion. Okay, so in such a, when there is such a fluid collection also in associated with the pneumonia, always remember, as I told before, that can actually interfere with your auscultatory findings. And not just auscultation, when you want to percuss also, this region of effusion would appear stony dull. Okay, because you know that effusion will be having a stony dullness. Whereas in case of pneumonia, you expect a dull note, or you can even call it the impaired resonance. Dull or an impaired resonance is seen in the region of a consolidation. Okay. All right. So always keep in mind the effusion, the parapneumonic effusion that can be associated with pneumonia. Okay. Now another patient with a mycoplasma pneumonia. So this is likely to produce a atypical pneumonia. Here you will have a diffuse bilateral interstitial infiltrates. It's not the typical lobar consolidation that you see here. It is the interstitial infiltrate. You have a AP view as well as a lateral view. So you can see bilaterally there are diffuse infiltrates, okay, in this patient with mycoplasma pneumonia. And yes, this is another patient. I'll first show this X-ray where you have an obvious arrow. But remember, in your exam, you're not going to get these arrows. So this is where, you know, you have an area of consolidation and you have the fissure being pushed down. And this is what is referred to as the bulging fissure sign. Okay, you are having a bulging fissure sign. Now, bulging fissure sign is commonly attributed to Klebsiella. It is commonly attributed to Klebsiella because Klebsiella, see, again, it has a predilection to involve the upper lobes, and Klebsiella involvement in comparison to other infectious agents is likely to produce this radiological sign, that is your bulging fissure sign. Okay. All right. So bulging fissure sign, and another MCQ that you can expect is the classical sputum of a patient with Klebsiella. I'm sure you would have guessed by this time. It is called the classical red currant jelly sputum. Okay, it is not current, it is not ENT, it is ANT. Okay, red currant jelly sputum. That is what you see associated with the Klebsiella pneumonia. Okay, very important. So maybe if they give a scenario of a Klebsiella pneumonia in the exam, the scenario might be that of an alcoholic patient. Okay, because we have already seen alcoholics are likely to develop Klebsiella pneumonia. Okay, all right. Now another patient. I told you pneumonia can go in for complications as well. So these are two complicated pneumonias. One here in which you can see the air fluid level. So this is a pneumonia which has on top of the pneumonia there has been an abscess that has developed. Okay, and on the other side it's not actually an effusion because see the trachea is actually central. So this is actually a severe necrotizing pneumonia that has occurred. Okay, severe necrotizing pneumonia in which it is affecting the entire left lung. Okay, severe so these are actually the complications that can develop in a pneumonia. So complicated pneumonia, it is always better that you go for a CT as well. Okay, all right. So the next one, yeah, this is a pneumonia where there is actually a cavitation also in the pneumonia. I hope you can see the cavity as well. And you can see it is that cavity can be demonstrated in the CT thorax as well. So he was treated with antibiotics, and in the subsequent follow-up you can see the resolution. Okay, so always, you know, in such scenarios it is better that you go for a repeat imaging also, because sometimes you might feel this is any other bacterial pneumonia which is not responding, there is some cavitation, but actually this might be a tuberculous pneumonia, because you know it can also have cavitation. But yes, certain bacterial infections like your staphylococcus, your Klebsiella can also produce this necrosis, cavitations, pneumatoceles. So again, it is a very tricky scenario because sometimes tuberculous pneumonia can be a masquerader. Okay, you might be treating for a bacterial, it might be a tubercular. Okay, all right. In this case, it was a bacterial because in the follow-up also the consolidation completely resolved and the patient was better. And remember, what about this patient? I'm not giving you the history. Just want to tell you that this is not a bilateral consolidation. This is just the typical bat wing opacities that you can see in case of a pulmonary edema. Okay, so always, when you get a clinical question with a chest X-ray, read the question, read the clinical scenario as well. Okay, otherwise you might jump and write this is a pneumonia, but this is actually a patient who presented with acute onset pulmonary edema, having this bilateral fluffy batwing type of infiltrates. Okay, all right. So this is pulmonary edema and infiltrates. So these are the important X-ray radiology findings. So chest X-ray, I hope you understood, forms an integral part of the diagnostic workup. But let me tell you some points. That is, see, if you are early in diagnosing a patient, sometimes the chest X-ray can be normal. You might be able to demonstrate some crackles or maybe some bronchial breathing, but chest X-ray initially might not show obvious finding. You are having some doubt. So remember that early cases sometimes X-ray may be normal. And another point is that, see, once you treat this patient, the radiological findings would lag behind the clinical resolution. Now, what do I mean by that? Which means sometimes in spite of your treatment, you have treated the patient and the patient is well. But even after that, sometimes you might have some consolidation. Okay, so keep that in mind. Radiological consolidation can lag behind. Okay, sometimes you can have a 2 weeks or maybe even a 3 weeks delay, because even after the clinical symptoms are gone, you might have another 2 weeks later only the radiology might completely be normal. Okay, so that also you should be careful of. Now, in addition to all these investigations, you also can have urinary antigen testing. Urinary antigen testing is mainly for two organisms. One is your Legionella, and also for your pneumococcus also you can go for your antigen testing. And also some cases you might go for the PCR testing also. So these are the important investigations that you should do in the workup of a patient with pneumonia. Okay, so I hope that part is very clear. So remember, you can get a lot of questions from these areas in the topics that I have discussed so far. Now coming to the treatment. I'm going to first describe it or discuss the treatment of community acquired pneumonia. How are you going to treat? Now this is again very important because I feel from a practical point of view, this part of discussion is the most important, because when the options are plenty, that is when you have all these confusions. Okay, that is the same rule applies for life also. When the options are plenty, same is here, you have lots of antibiotics available, so that is when you are likely to either under treat or maybe over treat, or maybe put the wrong antibiotic. Okay, your diagnosis might be right, but the selection of antibiotic might not be right. Sometimes your diagnosis might be right, selection of the antibiotic might be right, but the dosage is not right. So you have got to be like, when you treat a case of pneumonia, you have to be very, very vigilant, and you have to apply your mind, okay, especially in the antibiotic selection, because otherwise what happens is that you are knowingly or unknowingly contributing to the development of antibiotic resistance. Okay, so that should be kept in mind. So treatment of community acquired pneumonia. See, I'll be discussing with you two tables in Harrison, okay, on the treatment of community acquired pneumonia. But remember that in 2019 you have the guidelines. This is by the ATS, that is the American Thoracic Society, and the Infectious Disease Society of America, that is your ATS IDSA guidelines. So the previous guideline was there in 2014. They revised it in 2019. So I would be saying some points from these guidelines as well. But so as not to confuse this, first I'll say about the table in Harrison, about the management part, and I will highlight to you only the important points that you should know from the guideline. Okay, so we will not mix both these things. So remember, for the respiratory system also, you have various societies giving various guidelines, which is why you might see a different set of guidelines with, say, the BTS, British Thoracic Society. So guidelines can slightly differ between the various bodies, but again, in general, it would be almost similar. Okay, there can be minor variations. So let's see it from Harrison. Okay, see Harrison, when it discusses the treatment of community acquired pneumonia, so it is dividing the selection of antibiotics based on whether it is a OP based management or it's the IP based non ICU patients management, or if the patient is a IP and it is a ICU patient. Okay, that is how they have divided. The same rule applies to the 2019 classification also. There is a slight difference which I'll tell you. See, OP based means the selection of antibiotics depends on, okay, so we are dealing with the outpatients treatment. Okay, selection of antibiotic in a patient in whom you are deciding to treat on an outpatient basis. You're not admitting, you are treating on an outpatient basis. Maybe the curve score is very less, maybe 0. So if the curve score is less, you can decide on treating on an outpatient basis. In such a scenario, the selection of antibiotic would depend on whether the patient is previously a very healthy individual and for the past 3 months he has not received any antibiotics, versus a scenario where he is an individual with comorbidities like a chronic kidney disease patient on dialysis. Okay, or maybe he has got antibiotics in the last 3 months, which means he is likely to develop some antibiotic resistance because he has already received a recent antibiotic course. So the treatment depends upon that. Now, if you have a perfectly healthy individual, okay, developing a pneumonia, in such a scenario, the choice of antibiotic can either be a macrolide. Okay, so this macrolide again can either be a clarithromycin or a azithromycin. Clarithromycin or azithromycin. The guidelines do not favor one agent over another, clarithromycin and azithromycin, or you can have doxycycline. Now, you might ask me, then what about beta lactams? Don't you give beta lactams? The point is, see, the problem with beta lactams is that the atypical coverage is not there. Okay, if you have a mycoplasma, if you have a chlamydia, that will not be covered. Whereas if you have a macrolide or a doxycycline, you are able to combat both. Okay, the typical group as well as atypical group, which is why you have not included the beta lactam. But let me tell you one thing. In the 2019 ATS IDSA guidelines, they have added amoxicillin as well. Okay, they have added amoxicillin back, which means you can go for amoxicillin also, a plain amoxicillin also, for managing a patient on an outpatient basis with a pneumonia. Remember, the treatment that we are discussing, okay, this particular treatment of community acquired pneumonia is the empirical one that I am saying. Okay, is the empirical treatment, because we are at present at the initial presentation, you are not sure which organism has caused. You've got to wait for your sputum gram stain, maybe sputum culture. Sometimes you might not be able to demonstrate any organism. So when you empirically treat, the problem is you would ideally want to have a atypical coverage also, but the IDSA just know that. So that is one difference I would add to this table, that is you can go for amoxicillin as well. Now, if the patient has comorbidities or has received antibiotics in the past 3 months, let's see what difference does it make. Then comes that you can go for a fluoroquinolone. Okay, you can go for a respiratory fluoroquinolone, which can be your moxi, gemi or levofloxacin can be added. Or you can go for a combination of a beta-lactam plus macrolide. Okay, so you can go for a respiratory fluoroquinolone or a beta-lactam plus macrolide. So which means macrolide alone won't be enough. Here you can go for macrolide alone. But here, since he has received some antibiotics or he's having some comorbidities, I'm expecting that there might be some resistance or maybe a more virulent organism. So either I will go for a beta-lactam plus macrolide or I'll go for a respiratory fluoroquinolone. Clear? Okay. So that's about the outpatient based treatment. Very clear. Now what if the patient is in? Okay, if the patient is in. So beta-lactam, I know most of you know you can go for amoxicillin or amoxicillin clavulanic acid. So about inpatient, again they are dividing it into non-ICU and ICU. So non-ICU again you can go for a fluoroquinolone, a respiratory fluoroquinolone. Because of the curb score, you found that this patient is at a higher risk, so you have admitted the patient, but not to the ward, not to the ICU, maybe to the ward. Suppose the score was 2. Okay, so you admitted in the ward. So you can go for a respiratory fluoroquinolone or you can go for a beta-lactam plus a macrolide. The thing is that sometimes it is a hospital patient, you can go for a parenteral treatment. So that is the difference, because here, it is OP based treatment, means you are giving oral agents. So here you can go for parenteral agents. So parenteral, so you can, like if the patient is very stable, you can go for an oral also, but otherwise you can go for parenteral since the patient is IP. Now if the patient is IP and in the ICU, you can again go for a combination. Again, it is definitely going to be parenteral. You can go for a combination of beta-lactam plus either azithromycin or fluoroquinolone. That is a macrolide or fluoroquinolone. Okay. So that, the Harrison is telling. But I'll just, keep this in mind. When we come to the guideline, there is a slight difference, which I'm going to tell you. Okay, for the time being, you remember this. Understood? Now let's see what this IDSA has got to say. So IDSA, just actually comparing with the previous guidelines. So this is the 2019 guidelines. So the recommendation is that, okay, they have listed several recommendations. I'm going to tell you about the 2019. We are not going to discuss the 2007. It is just that they want to make a comparison between 2007 and 2019 guidelines. Okay. So let's see this. The sputum culture. Previously, they said the 2007 guidelines said, sputum culture is not very imperative. But now they are specifically recommending the sputum culture. Similar is the case with blood culture. The previous guidelines said, only in severe disease you need to go for that. But here, in patients with severe disease as well as the ones with moderate severity also, you have got to go for a culture. So remember, the guideline says sputum culture and blood culture in all patients with pneumonia who is being admitted. And see, next point is regarding this the empiric therapy of severe community acquired pneumonia. That is the point I want to stress. You remember, I told you for a ICU treatment you can go for beta-lactam plus either azithromycin or fluoroquinolone. They had not put one agent above other, that is whether you should go for azithromycin or fluoroquinolone. But in the 2019 guidelines, they are specifically saying both are accepted, but the evidence is more in favor of the beta-lactam macrolide combination over the beta-lactam fluoroquinolone combination. So when you now have an ICU patient, you should favor a beta-lactam plus macrolide combination over the beta-lactam fluoroquinolone combination. Okay. So why I am showing you this guidelines is because guidelines are guidelines. Because see, when you treat a patient, suppose there is a litigation against you for since the patient like in the current scenario there are lots of instances of such scenarios. So see, if you are asked regarding the justification of your treatment, you should quote guidelines. See, you can have certain logical changes, but if the general protocol, like going for a particular antibiotic, the choice of an antibiotic is very important. Okay, so the preferred agent would be a combination of beta-lactam and macrolide. And this one I have already told you, the use of the term healthcare associated pneumonia. Previously this was there, but you see it recommended the abandoning this categorization into HCAP. And many of the centers use this procalcitonin for measuring the response, whether the patient's infection is being controlled. But mind you, it is not at all recommended for the either for the selection of the antibiotics nor for the subsequent tapering or downscaling the antibiotic as well. Procalcitonin is not recommended. Okay, so these are the important points. Rest you need not know, but these are the important points with respect to the guidelines that you should know. So I hope you are very clear with the management of community acquired pneumonia. How do you stratify it? How do you select antibiotics? Importance from an MCQ point of view, in the exam they might give a clinical scenario and you might be asked what is the antibiotic that you would choose. So for that, you first see it's a community acquired pneumonia. Is the patient in the ICU? Then okay, the option has beta-lactam plus macrolide, you choose that. Very important. Okay, now this was about the empiric therapy. Now suppose if you get the culture reports and you find that the organism that has caused is Pseudomonas. So if the organism that has caused is Pseudomonas, then you should shift to either a meropenem or you should add a piperacillin tazobactam. Piperacillin tazobactam. Okay, all right. And suppose you get MRSA. Okay, you get MRSA, methicillin resistant staph aureus. In such a scenario, you should either go for your vancomycin or linezolid. Okay, so this depends on whether the culture reports are available, what is the organism. So you have got to keep in mind. So whatever we discussed was the empiric therapy, and then if the specific organism is identified, you have got to manage accordingly. Okay. So now let's discuss the treatment of ventilator associated pneumonia, VAP. So remember that both VAP as well as hospital acquired pneumonia are managed more or less in the same way. Okay, so whether it be VAP or whether it be HAP, what is that you are concerned of? You are concerned of one factor, that is drug resistance. In fact, multi-drug resistance is what you are concerned about. So the point I want to tell you is, in a hospital setting, especially the ICU setting, you are more likely to encounter organisms that are resistant to multiple antibiotics. Okay, because see, ICU is a scenario where all the antibiotics you use will be a higher end antibiotics, correct? No? So when you use such antibiotics, the chance of the microbe developing resistance to such antibiotics is more, which is why most of the cultures you send to from patients with a VAP or HAP turn out to be multi-drug resistance. Okay, so that is what you have to be careful about. So what are the organisms commonly implicated in your VAP and HAP? See, you may have like drugs, agents which are resistant to which are responsive to antibiotics as well. Okay, it is not that all cases of VAP and HAP are due to drug resistant organisms, but again a significant chunk are. So the organisms that you are a bit scared of, it can be the multi-drug resistant Pseudomonas, it can be the Acinetobacter, or it can be your MRSA. So predominantly it's the gram-negative pathogens and MRSA that you are scared of in case of a VAP. Okay, so your drug selection also should be judicious. So what decides your drug selection in such a scenario? It is based on the risk factors that a patient has. It is not that all patients with a VAP or a HAP are managed in the same way. It is like it depends on the risk factor profile of the patient as well. Because initially you have got to go for an empiric therapy, and only later you would go for once you get the culture results, you go for a definitive, maybe the organism targeted therapy. Okay, but your empirical therapy should be very sharp. It is not that you can give any drugs for your empirical therapy, because that initial therapy should be the one which should be able to contain the infection. Okay, so let's see how you are going to plan this antibiotic therapy in a VAP. I told you it depends upon the risk factors, and let's see this table from Harrison, which shows the empirical antibiotic treatment of HAP and VAP. I told you it depends upon the risk factor profile. So it depends whether the patient is whether or not the patient has a risk factor for gram-negative pathogen. So here no risk factors, or whether the patient has a risk factor for a gram-negative pathogen, or whether there are risk factors for MRSA. Okay, so that is the basis of selection. Now, if there are no risk factors for a gram-negative pathogen, in such a case, you can go for either of a piperacillin tazobactam, cefepime, or a fluoroquinolone like a levofloxacin. So you can go for either of these parenteral drugs. Okay, but when there is a chance of resistance, one drug might not be enough. So that is a scenario you will have to go for 2 drugs minimum. So you have got to choose one from each of these tables. It can either be piperacillin tazobactam, cefepime, ceftazidime, imipenem, or meropenem. Either of these antibiotics, you can choose one. Okay, because they are having more or less the similar spectrum of action. Plus, you should add either an aminoglycoside or a fluoroquinolone, or you can go for colistin, or you can go for polymyxin. Okay, so you've got to add 2 agents. Maybe you are adding a meropenem plus colistin, or a piperacillin tazobactam plus maybe a fluoroquinolone, like that. Okay, so maybe the selection of the drugs would depend on the sort of antibiotic resistance you have in your ICUs as well. Suppose your ICU harbors a lot of colistin resistant Acinetobacter, then based on the previous reports of maybe another patient in the ICU, whatever it is. So because the profile of the microbes in the ICUs will be more or less same. So in such case, do not go for colistin, go for something else. So that is important. Okay, so antibiotic selection has to be very wise there. Now, in addition to this, remember, in addition to this, if there are risk factors for MRSA, I've got to treat with either linezolid or vancomycin. Okay, that is important. So if the patient harbors risk factors for both gram-negative as well as MRSA, you have got to have a minimum of 3 antibiotics. That should be there. Maybe you are adding a piperacillin tazobactam plus maybe a fluoroquinolone plus maybe a vancomycin or a linezolid. Okay, so that is how you have got to combine your antibiotic. So antibiotic selection is very important. It's not that you randomly choose one antibiotic and fire it on a patient. You have got to use judiciously, because otherwise chance of development of antibiotic resistance is high, which is why you have got to be very vigilant, especially when you deal with an ICU patient with a pneumonia. Because if you're not following a good antibiotic protocol in your ICUs, it is likely that the antibiotic resistance will be there, and then you will have that most of the organisms in the ICU associated infections will be multi-drug resistance. You just cannot do anything. You will just have to sit and watch. So such a scenario, always be careful. So VAP, empirical therapy, and then if a specific organism is identified, you can adjust accordingly, but you have got to have a very aggressive treatment for your VAP. Okay.